Good morning, and thank you for joining me in this talk on this very important topic on quality and safety programs in operation rooms, challenges and strategies. At the outset, let me thank the organizers of ISACON 2021 for giving me the opportunity to talk to you on this issue. As we know, this quality and safety is closely related, which has been deliberated at length at various national international forums. And with increasing time, there is increasing awareness regarding implementation of quality and safety programs in hospitals. Let us look at some of the challenges, some of the strategies, some of the literature available on this particular topic, and discuss on this particular issue. In the background, I would like to talk to you about this concept of Donabedian model of structure, process, and outcome, where, as we know, the structure is the operation theater, the hospital environment, the various equipments, and the staffing which is going into the system. The processes, as we know, are various protocols, the orders of the physician, or cleaning, nursing, or also the safety checklist. All those aspects can come under the process. And the outcome is the satisfaction of the patient, the patient outcome after the surgery, post-operative, etc., etc. I would also like to brief you on this particular model of SISTUS, where you can see there is a procedure which is happening, which is leading to the death, provided all the holes in this particular segments are open. So that means that in order to commit a major mistake or leading to the mortality of a patient, only one component going wrong is not enough. We need to have so many occurrences in a row so that this mortality happens. So indirectly, I mean, whenever there is a major catastrophe, it is due to the various failures of the system. Another aspect I would like to touch upon is about the ventilation. The infrastructure, the modular OTs have come in many of the hospitals now, and the ventilation is a very important aspect in the quality of theaters. So as per the guidelines of the NABH, we need to have 20 air changes, and there has to be a flow of air which is coming to the operation table, and the velocity of the air 25 to 35 feet per minute. And there has to be a validation of the system in every 6 months regarding the temperature, humidity, air particulate count, air change rate calculation, air velocity at the outlet, pressure differentials, and validation of HEPA filters. And the preventive maintenance of the system has to be done in 30 days. Of course, we know that the positive pressure has to be maintained, and the air quality has to be maintained with HEPA filters, which is having efficiency of 99.97% and a temperature which is kept between 21 plus or minus 3 and ideal RH of 55%. Another important aspect that we need to discuss is about the surgical safety checklist. This has been implemented in a lot of hospitals across the globe, and the various steps which are there, many of you are familiar with the sign in, time out, and the sign out processes. In the sign in, the patient ID is checked, the site is marked by the surgeon, informed consent is taken, and if there are any allergies are checked, and the blood group is checked, and there is a pulse oximeter functioning for the patient, and we have also assessed the aspiration risk of blood loss, etc. In the timeout procedure, that is just before the surgery, we need to confirm the patient procedure, position, and the consent, site marking, antibiotic prophylaxis, DVT prophylaxis, aseptic techniques implementation, and blood loss anticipation, etc. Then we go on to the surgery, and the prophylactic antibiotic is also given prior to the surgery within 60 minutes of the incision. After the surgery, we look at the level of consciousness, we look at the ID band, we look at mostly the counts with regard to the surgeon, counts with regard to the nurses, counts with regard to the anesthesia team, all of them are checked. The various studies for surgical safety checklist, this is one of the studies that is there, published from the USA, and they have adopted a study, and the key summary points are: surgical checklists are a promising intervention, it has been successfully adopted, and surgical safety checklists were associated with increased detection of potential safety hazards, decreased surgical complications, and improved communication among operating staff. However, key components of the successful checklist implementation include support from the leadership, training of the staff, adapting the checklist, and avoiding the duplication of information already collected. In another study at Norway, various safety cultural factors were assessed in a longitudinal study 2009 to 2017, and we can see that overall patient safety, the support of the patient, the teamwork, the error feedback, staffing, and teamwork across the units, they are all improved over a period of time. Another study on the safe surgery checklist in Brazil, where we can see that 95% of the cases, there was a checklist in the medical record, whereas the qualitative study revealed that only 67% of the medical record has a 100% filled out checklist. So you can see that some of the aspects like surgical procedure, the proposed procedure, informed consent form are more than 90%, but many other parameters are not recorded in the checklist. In a study which is published in the Journal of Thoracic and Cardiovascular Surgery in 2015, they analyzed about 30 adverse events in cardiac surgery procedures, and despite 100% compliance with preoperative surgical checklist, adverse events occurred that were specific to nuances of cardiac surgery. And so they suggested that checklists be customized and modified if they are to be effective in cardiac surgery. So, which all state that definitely the checklist is a good form of intervention in improving the patient safety in theater, but that is not enough. We need to do more. Then coming to another study on the medication safety. So they have seen that there are total of 35 specific recommendations they have brought out to have medication safety. Adverse events as a result of medication error occur frequently in the operation setting, and there are not many studies to direct the medication safety strategies. And the overwhelming consensus regarding the best practices should be adopted, and the recommendations implemented. And the drug list included the medication reconciliation, the automated alerts, the cognitive aids for drug information, the management of the cart inventory, and usage of single-use vials preferable, and if multi-dose vials are required, discard at the end of the case. So there are many recommendations which we can take it forward. With regard to the study on this near miss and the retained surgical sharps, in a US study which is published in the Patient Safety in Surgery, they opine that the current methods of prevention are costly in time and resources without improvement in patient safety, and there is definitely strong understanding of these implications is important as we strive to improve patient safety. So if you can see this slide, only 10 to 20% of the cases, it is never happening. That is incidence of lost sharps or miscounted sharps. They are not happening only in 20%. And there is 1 out of 100 cases in about 60% of the cases. So even in best of the situations, the retained surgical sharps and near misses are a common occurrence. This is another interventional approach where they did a multidisciplinary team for the quality improvement, and the persons who are reporting the hazards, they are actually given an award. So they have put it as the S bar, and they suggested that a multidisciplinary team's analysis and mitigation of hazards identified in a patient safety reporting system, positive recognition with a good catch award, education of practitioners, and long-term follow-up resulted in an outcome of sustained quality improvement initiatives. The nexus they have recommended in a study conducted in 2018 in Brazil, 24.7% the use of safe surgery checklist is a good practice, and establishment of safety culture, they are the major aspects of improving the quality systems in hospitals. It also includes other factors like continuing education, availability of resources, involvement of multi-professional team, etc. In another study in British Journal of Anesthesia, improving patient safety in the operating theatre, they have reviewed and analyzed reasons for the lack of progress in improving patient safety across. So they review the team training interventions and tools available for the assessment, and they said that the human factors are the major contributors to errors in healthcare that can impact patient safety. Improvements in the safety and outcomes of hospitalized patients have been slower than expected, and healthcare team-based approaches, including simulation, standardization, and training, would further improve patient safety. How about the patient handover in the postoperative part? So they say that the training in team skills and communication should be promoted, and these recommendations have the potential to improve the quality of postoperative handovers and safety of patients during this critical period. So this is a communications in the theater that is very, very important. Another study again in BMJ on task, multitasking and interruptions among the surgical team. So they have listed various interruptions like equipment related to procedure, related to medication, change of shift, alarm, external factors, etc., and telephones. So there are so many factors which are distracting the operative process, so which should be minimized, and we should bring about various changes in the operation theater to reduce the distractions like opening of the doors, entering of new people into the theater, etc. Then another study, BMJ opened, effectiveness of a multi-component safe surgery intervention in improving surgical quality in Tanzania. They have advised that the leadership and teamwork training is important, clinical training in safe surgery, sterilization training, data quality training, and infrastructure support and training. They are all safe surgery interventions. The managerial challenges in quality improvement include defects and delays in patient medical records, irregularity and lack of transparency in directions of process in the hospital, inappropriate and unrealistic operating scheduling, and poor safety management. This was published in the Journal of Education and Health Promotion in Iran. So they have brought out some of the solutions like appointing a person for equipment, for medical records, clarifying the process path of admission, developing a regular monitoring program, training, etc. National Patient Safety Foundations, they have come out with some of the recommendations like establishing a safety culture, centralized and coordinated oversight of patient safety, creating a common set of safety metrics, address safety across and supporting the workforce, partnering with the families, and ensuring a safe technology, etc. In a study which included elective general surgeries, they have come out with the recommendations that the surgical complications decreased from 22.9 to 10% after checklist implementation. So what are the various strategies which can come in for the various challenges that we have? So we need to create a good infrastructure, modular OTs AC, where we need the support of the policymakers, multidisciplinary team, implementation of quality safety practices, WHO safety checklist example. So there we need team training, safety culture, evidence-based medicine, and building redundancy. Preventing adverse events, again, you require this ID tags, site marking, safety culture, embedding simulation into training and practice, and selection of competent professionals, standardizing assessment, etc. Another important aspect is prevention of surgical site infection, where preoperative preparation is important, timely antibiotic prophylaxis, infection control committee and the team and the surveillance, the training of the team, normoglycemia, time management, and the postoperative care. Medication safety is another challenge that we have already seen in one of the studies, and labeling, safety culture, repeated checks by various teams, and proper inventory management, and incident reporting with a root cause analysis and corrective and preventive actions are important. Fire safety is a major concern, which is not really addressed. So this need to be addressed during the planning of the theater, proper access have to be provided, and fire exits have to be there, and we need to conduct mock drill, code red, and the proper training of the people in all the various categories have to be made, and also the trolleys and the manpower have to be made available. Radiation safety is another concern, where we need to have dedicated equipment for the theater. Appropriate technical support is usually not available, but we need to train the people in appropriate usage of radiation safety devices, lead aprons, and training, and the SOPs have to be followed. Occupational safety is another concern, where the vaccination of the staff, health checkup, regular is also important. SOPs, simulation training, creating a safety culture, and structured communication and incident reporting are strategies for dealing with this important issue. Avoiding hazards, cautery burns, injuries, and sharp injuries. These are all important to address. We need to have a good positioning for each of the surgeries. There has to be people in maintenance, training has to be there, incident reporting have to be done, and proper management of the biomedical waste, especially the sharps, and avoiding distractions and the structured communications are important. Electrical and equipment safety is another major issue where we need to focus on the BME, maintenance, team training, quality in the purchase, following up the SOPs, and steps like conductive flooring are important. Change management is a major challenge in implementing the quality and safety programs, and there is a resistance among the staff. So what can we do? We can definitely have a continuous engagement with the staff. We can incentivize them, and then over a period of time motivate and give them the better aspects of the quality and safety for everyone, including the staff. Inventory management is also another major issue where we need to bring in good, sound inventory management practices in keeping up the stock of various drugs or consumables, and also making it available based on the OT schedules. And the training of the team for the inventory management is also equally important. So I have tried to conceptualize some of the various concerns in implementation of quality and safety programs in operation theaters, and some of the strategies which we can adopt. Major strategies include simulation training, team training, sensitizing them, and retaining a good team in the operation theater, along with providing good infrastructure. Thank you very much. I bring to you the greetings from the Department of Hospital Administration at AIIMS Bhubaneswar. Thank you very much.